Thank you for that. I'd just like to acknowledge the traditional owners of the country here and acknowledge their ongoing relationship to the land and thank them for being able to talk here today. As mentioned, I've had the privilege to work across different areas, working directly with people on the ground, but also found myself caught up in a role of sort of overseeing a service and finding myself stretched between the ground and sort of the realms of political and bureaucracy and trying to draw the two together. So it's been interesting and challenging. I'd just like to briefly, if I can, just share a bit about the background of the Street to Home service in Adelaide and maybe draw upon some of our experiences and learning over the 5 or so years and maybe just highlight some ongoing matters and challenges that we come across. The Street to Home service in Adelaide is a primary healthcare service that's part of the Department of Health and also sits in the Adelaide Health Service. So it's a government service. It commenced in mid-2005 and it was established following a number of processes. Firstly, there was a visit by a thinker in residence, Roseanne Haggerty, from a similar program in New York. That was taken up by the Social Inclusion Unit, which sits in the Department of Premier and Cabinet in Adelaide, and that led to a commitment by the South Australian Government on initially aiming to reduce the numbers of people sleeping rough in the CBD by 50% by the year 2010. The service sits between two departments, Departments of Families, Communities and Health, and we have some oversight by the Social Inclusion Unit. So that's where we sit. So we commenced initially working in the inner city and we pretty much tried to hit the ground running and develop processes and tools as we went, drawing upon some of the ideas from the New York model. I'll just give an overview of the service, if that's okay. Basically, we comprise of a team of workers from different disciplines, including Aboriginal health workers, social workers, nurses, and an occupational therapist. All the workers undertake generic case management, and as I said before, the initial focus was working with people in the inner city, and we achieve that by providing case management. We go out 7 days a week and do street work with the aim of trying to locate, identify and engage with people that are sleeping rough, and then work with them to achieve, hopefully immediate accommodation and then ongoing support as needed. We also operate a duty system so that whoever needs support can contact the service and get immediate support and assistance into attaining accommodation or other support needs. As I said, the service operates 7 days a week, and over time we've developed a number of formal sort of clinical tools and processes and resources that we've found are effective in trying to meet the goals of the service. One other important mechanism of the service, apart from the work on the ground, is our connection, is the governance system, and that we have fairly sort of intense scrutiny by steering bodies, and we have a frequent reporting mechanism where we need to report up outcomes and other evidence of our practice on the ground, which can be a bit daunting when you're reporting up to 3 different bodies, but actually can be quite useful in terms of maintaining support to the work we do on the ground. Since the service has been running, we've seen some changes. The service has increased its role, and we operate across the whole metropolitan Adelaide, so out into the far suburbs, etc. This has changed a little bit of the nature of our work. We still go out and street work, but we haven't got the capacity to cover the whole metro area, but we do receive referrals from all over, and as our service increasingly gets known, we go out and engage people wherever they present, in the hills, down on the beaches, etc. Over time, we've improved our connections across both the government and the non-government sector, and developed formal communication and pathways for clients between services, from street to home to mental health to the hospital sector, for example, drug and alcohol services. So there's been a focus on developing an integrated system within government, and there's also some current work going on around integrating the non-government sector to ensure that wherever someone presents, they get captured into a service system that ensures they don't fall out and they get supported onwards and out of homelessness. That's also being supported by, you may have heard of they're developing a statewide IT sector where people can be captured into that, in a word, and ensured that someone is always providing support. Over the 5 or more years, we've found out the model we use has been effective. We've tweaked it a little bit as we go, but it's seen its importance in being able to firstly identify and engage with those people that other services, they're not receiving a service, they're isolated, they're vulnerable, they've got high needs, and because they're homeless, they're not coming to the attention of anyone else, so which is the service works solely on an outreach basis, really to go out there, seek, use whatever tools we can find to try and locate people and to connect with them immediately. We then engage them through an assessment and building rapport process where persistence, we go back, we try and work with the presenting needs, whatever the client raises of their issues, and then we continue to work with them on a one-to-one basis as long as needed, into housing and beyond, until they're either have achieved a level of their own capacity to continue on, who will have access to some ongoing supports. As I said, some of this is reflected in some of the articles in the Parity magazine, but the Street to Home Service has adopted some really clear principles that inform how it works. The most important being the Housing First model, which we've tried to implement, and I fully agree with a lot of the other comments around Housing First is only as good as housing or accommodation is available. And even supporting someone into some form of boarding house or transitional accommodation is, in one sense, can be argued to maintaining people in a sense of homelessness. We put a lot of value on clients being fully participating and being involved in the process, so we work constantly with them around trying to articulate their goals and work towards what they see are their needs, and that can be everything from accommodation to reconnecting with family members, dealing with substance use, whatever the needs may present. We have a strong focus on working holistically, so we work across every domain of support. You know, we could be addressing financial issues, debt issues, connecting with legal support, family, mental health support, whatever's needed. As I said before, we work over the long term, as long as needed. Some people we might work only up for a number of months, others we've had on, we've been assisting for over 2 years. So all the work's done on outreach on a one-to-one basis, so one worker per individual, so you actually over time build up a really good working relationship with that person and have the privilege of sharing some of their stories and understanding what's going on for them, and so people don't have to continually reconnect with other supports along the way. We try to address systems issues that we come across and develop better integration between the sector, if there's gaps or barriers between services, to ensure that homelessness is on the agenda with other departments as well, and trying to fulfil the role that homelessness is a responsibility of everybody. From that, we've found out that many of the clients we worked through have had long histories of homelessness. Some have been homeless for a good part or almost all of their life. We've worked with individuals that have gone under the radar for 20 years right in the middle of the city, people who have just been constantly cycling through systems and services, falling out of mental health sectors, hospital systems.